See if I can get these people back. Yes. Yeah, I don't know what happened, man. I don't know what happened. Like I said, I'm a noob to this whole live stream thing. So I pressed something, I screwed the whole thing up. Anyway, let's get back at it. So the question that please, you're gonna have to redo your questions because I lost the chat. So I don't know what's going on. But the question that I was answering was, how to be a best advocate for yourself. So I always allow patients to ask my questions, and the last thing that I'll say to them before they leave my office is, are there any additional questions that you have, or anything else that you would like to ask me, right? And so this gives them an opportunity to say whatever it is that they need or for clarification. And, you know, I do this within reason. And you've got to understand, like, when I'm seeing people in clinic, my consults are scheduled for 30 minutes and my follow-ups are scheduled for 10 minutes. So 10 to 15 minutes, depending on which clinic it is. So people really need to be, concise with their questions and what they're asking so that I can answer it clearly. And sometimes people ask a lot of questions when they really don't really care about the questions. What they want is reassurance. And like, I can only reassure you to a certain extent, because when it comes to surgery, there's always a risk of potential complications or problems. So, you know, I can quote to you what the risks are. I can tell you what are the precautions that I would take. But, you know, if you're looking for comfort and reassurance, I can't always give that to you, right? I can just try to answer your questions and make you comfortable. But so what I would say is for you to prepare your questions, not an inordinate list of questions, have those questions. And if you have read something in Google that you want to ask about, don't say, oh, well, Google said this. Say the way that I would propose it to broach that with your physician or your surgeon and say, well, do you have any opinion on X, Y, or Z, right? I would ask a limited number of questions. So prioritize your questions in order of importance. And I would probably, depending on the length of the interaction, so if it's a consult and it's a half an hour, you know, you could ask 5, 6, 7 questions. And if it's like a follow-up, it's only a few minutes, then you can only ask a few questions, but figure out what questions are the most important to you and then ask what their opinion is, because their opinion will give you an idea of whether they are comfortable doing that thing, ordering that thing, or proceeding in that way. If they are not, they'll let you know what their opinion, and then you'll know whether you can proceed down that line of questioning or not. So that's how I would approach that. Boom. Okay, so what is your favorite medical machine? Mine is the MRI. Well, I'm assuming that you must be in radiology, you know, be a radiologist or a tech, MRI tech or a radiology tech. The MRI is definitely a very cool piece of kit, man. And especially these days, if you have a 3 Tesla magnet or stronger, and for those of you who don't understand or don't know, Tesla is the measure that determines the strength of the magnet in an MRI machine. And the stronger or the higher the number of Tesla, T, then the better the resolution of the pictures that you're going to get. So we used to have like 1 Tesla, 1.5 Tesla magnets. Those were the standards. But now we have 2.5, 3 Tesla magnets. And the resolution is absolutely amazing. You can see almost anything. So the MRI is definitely a very cool piece of kit. There's lots of cool things that I like in orthopedics and lots of cool pieces of instrumentation. But one of the things that I like the best is tied to one of the procedures that I like to do the most. Even though I'm not a trauma guy primarily, I love to do femoral fractures, either intertrochanteric hip fractures or femoral shaft fractures. And that's because using fluoro, which is a type of radiology, and the nail insertion guide, I can fix a femur fracture, femur being the longest bone in the body, the biggest bone in the body, your thigh bone. I can fix that through 3 1-inch incisions using that guide. And so to me, that's the coolest shit ever, right? And I love to do that surgery because it's a bad fracture, and yet I can fix it in half an hour to 45 minutes through those tiny little incisions. And then immediately after I fix it, a patient can get up and walk on it. You can come in with a broken thigh, bro, and I can fix it in 45 minutes and you can walk. Like, that is amazing to me, right? Every time I do it, I am absolutely giddy because I just think this is the coolest shit ever. Can tachycardia be caused from natural overproduction of adrenaline? Of course it can. A friend of ours, my wife and mine, had an adrenal tumor. And so it was a benign tumor that was on the adrenal gland. And because of that, she ended up having super high levels of epinephrine circulating through her bloodstream. And the way that they discovered that she had that tumor is because her blood pressure was freaking through the roof and her heart rate would race like for no absolute reason. And this is somebody who was healthy prior to the onset of this tumor. And so this was going on for a few months, and her blood pressure was like not responsive to antihypertensives, and they couldn't figure it out. And and actually, her being an advocate for herself, because she was trying to figure out, as with the doctors, what were going on. And so she did a bunch of reading, and one of the things she came across was adrenal tumor. And so she requested actually an MRI of her kidneys. And then when they did that, they found the tumor, and she ended up having that removed. And fortunately, she's fine now, no issues. But certainly a tachycardia, racing heartbeat can be caused by overproduction of adrenaline, for sure. So Rex Mimo, any thoughts on ashwagandha or on the positives and negatives of the body of doing martial arts? Good example of being how people love Brazilian jiu-jitsu, but it can really wear on your body. So first question, any thoughts on ashwagandha? So I don't have a lot of experience with it. I haven't looked at it in detail. I did watch a few videos on it after listening to Andrew Huberman from Andrew Huberman Labs, after listening to him talk about it. And it's something actually that I looked into taking for myself for a number of reasons, but one of which includes blood pressure control. So yes, I'm a surgeon, and my job is very high stress. And also I have a family history which is positive for hypertension. So even though I'm relatively fit, I was monitoring my blood pressure over time and seeing it starting to creep up a little bit as I get older. So ashwagandha was one of the things that I looked at to help out with that, and also for its effects on testosterone. Because as I get older, just being as I get older, my testosterone level will decrease, and which is a normal part of aging. But do I want, obviously I'd like to try to maintain that as high as I can naturally without, taking TRT or taking steroids or anything like that, because I don't really want to get into that can of worms, because that once you open that box, you're not getting out, right? So one of the biggest issues that I have with TRT or hormone replacement therapy for women is that once you start taking it, your endogenous or your natural production of testosterone decreases, and then your gonads basically tap out, and that you need to stay on it for life to feel normal. So I really didn't want that, but ashwagandha is a way that can help increase that just by taking that oral supplement. And so I thought I would try that. And it's not something that you need to necessarily take every day. So I have a little bit of understanding of it. And I think that, you know, as a natural supplement, you can take it over the counter. You don't need a prescription for it. So I think that is okay. But again, you really should watch a few of the videos on it so that you can just understand what's the optimal way to take it, what's the optimal frequency, because it's certainly not every day. And if I remember correctly, that you need to have like 3,200 milligrams or something like that, you know, every like several times a week. So you should look at the format that you're taking, what is the concentration or the amount of ashwagandha that's in it, and look at some of the videos on what's the optimal way to stagger the intake, both with respect to frequency and also, you know, do you do it once a day intake, or is it BID twice a day? Yeah, so I look at that. The next question, Brazilian Jiu-Jitsu. So the Brazilian Jiu-Jitsu has become quite popular for a number of reasons, one of which is UFC and MMA recently. And so I'm a fan of it. I don't do it myself, although I have people in my gym who do participate. But I don't do it. I tried it initially a long time ago, but it didn't really, you know, excite me at that time. I went instead to Taekwondo, and I went a little ways up, almost to my black belt in Taekwondo. But Jiu-Jitsu, I think, is pretty cool. It is very hard on the body. And I've done a number of podcasts with a guy named Mike Pekarsky, Dr. Kickass, over on Instagram, where we talk about injuries as a result of jiu-jitsu and mixed martial arts. And yeah, it's hard on your body because of the positions that people go into, and because it's submissions is a big part of it. And for the submissions, most of the submissions are based on smashing the shit or damaging somebody's joints. Right? Like, so any joint lock is the whole intention of that, if you actually were to do it fully, is to demolish somebody's joint, their knee, their ankle, their elbow, like you're trying to dislocate stuff. So a dislocation is not a good thing. And if you participate in that, I think you really need to be careful about the gym that you go to and the people that you train with, because you have to make sure that that they have the best intentions in mind and about getting good at it without damaging their opponents. And so I hear stories, and I treat people who have been injured from jiu-jitsu. So I don't have anything particular wrong with this, with the sport, but you really need to be cautious about who you're training with and what is the philosophy of the gym that you go to, so that you can minimize your exposure to injury, because injury is a very real thing, even at the highest levels. Man, listen to Gordon Ryan talk about his ankle, and watch him when he's when he is you know, rolling with other very, very high level athletes. Man, they're going out to like destroy each other's joints. So that's what you need to be cautious of. A huge fear for me is CTE, even for light sparring competition. I hear you, Rex, man, and that's the thing. CTE is a cumulative thing, right? So you have to be very cautious of how often you get hit, and how hard you are getting hit when you're sparring. And the thing that people don't understand, like CTE is, you don't even necessarily need to be getting hit super hard for you to have CTE. There is some evidence that soccer players have CTE because of frequent subclinical impacts to their head when they head the ball, right? Like, we're not talking about being knocked out. All they're doing is heading the ball, and you could get CTE from that, or you can have chronic problems, closed head injury issues because of that, even though clinically you don't feel like anything. So that's something to be aware of. And I'm not telling people not to play soccer. I'm not telling people to spar, but you should be cautious when you are sparring to try to minimize the amount of exposure you get to head blows, right? Because that's a problem. Let me see. Ryan Haggerty, Dr. Chris, happy holidays. Hey, happy holidays to you. Question about recovery. If I use gravity to assist blood flow, moving the target area above and below the heart repeatedly, would that speed recovery? It's a good question. We always want to improve blood flow to an area. Because the more blood flow that you have to that area, generally speaking, the more nutrients, healing factors, and all those things you're going to bring to the area. But that's a lot of work what you're doing about talking about, repeatedly moving some up and above the level of your heart or above the level of the injury to increase blood flow. And you can do the same thing just by keeping it in a stationary position in terms of height, but flexing and extending your fingers or flexing and extending your toes, and that's going to be just as effective, right? Using the activity of the muscles around that joint or around that injured area, that will bring blood flow too. So you could do what you want, but what you're talking about, but that involves moving that injured area, which might cause pain. And so you're probably better off just doing a flexion extension of the extremities beyond that point so that you can bring blood flow that way. So Chemistry Easy says, how do you deal with sleep deprivation or insomnia during residency? Oh, shit, man. Well, so you remember when I said earlier that I had an issue with depression? Well, that's part of it, man, because I remember them saying something, which I've heard them say in the military, but this is true of residency as well. Eat when you can, sleep when you have. Eat when you can, sleep when you can, have sex when you can, because you really don't have time to do any of those things. And it's very, very true. So it's very, very difficult to deal with sleep deprivation. And things like the rules now surrounding residency are much better. They have a lot more rules around than the hours that people can work so that they stay safe and so that they maintain physician wellness. But when I started my residency in 2000, we didn't have those rules. And so at that time, every third day, I used to be on call overnight. And so that basically meant I stayed up every 3 days. I stayed up for 36 hours in a row. And then the next day, we were supposed to be able to go home at noon, but they frowned on, they looked very poorly on you if you went home. So we would stay till 5 anyway. So basically, I would stay up for 36 hours in a row. And it sucked. But I just tried to get sleep whenever I can. And the thing that led to my depression that I had during residency was largely sleep deprivation. That is a torture, and it can really do something. A lot of people think, oh, they can do fine. They don't need a lot of sleep. Bullshit. You may think that you need a lot of sleep, but your body needs it. And coffee, I was never a big coffee drinker, but people swear by it. Coffee, they think it keeps you alert. It doesn't really. It just gives you the sensation that you're alert because it kind of staves off that sensation of tiredness, but you're not really any more alert than you would be otherwise. You really, at the end of the day, for your own health, you need to sleep. And so you need to really, really be on top of your sleep hygiene. You really need to not mess around with your sleep time. And what I mean by that is that your body likes for you to get up at the same time every day. Your body does not like for you to sleep in, and your body likes for you to go to sleep roughly at the same time every day. So this is something that I didn't really learn during residency, and it wasn't until afterwards as an attending physician that I finally realized this. With the help of a sleep physician, I actually had to be treated for a while so that I could learn that. And I do use melatonin every once in a while. I don't use it that much now because it's not something that's meant to be used long term. But I do use melatonin on weeks where I'm having trouble getting to sleep. I will use 5 milligrams, or if I'm really, really tired, I'll use 10 milligrams, but and I'll use that approximately half an hour to 20 minutes to half an hour before I want to go to bed. It is like a sledgehammer to your daily, or to your endogenous melatonin levels, right? Because we produce that ourselves, and that's what tells us that we want to go to sleep. So sometimes when we're not responsive, you can use a sledgehammer, bang, a big exogenous dose, but you should not do that more than once or twice per week to reset your sleep cycle, and then after that, stop. So I will do that occasionally, but generally speaking, I try to go to bed at the same time every day. I try to go to bed between 10 to 10:30 because I'm up at 5 to 5:30 every morning, and I'm trying to get minimum of 7 hours of sleep. And sometimes on the weekends, I might try to extend that to get 8 hours, but my body is so highly attuned now that even when I try to stay for 8 hours, I can't. Because at 7 o'clock, or at 7 hours, I'm feeling pretty restless, and I don't. It's not really good sleep, so I'm getting up. So keep your sleep time the same, regardless of what you're doing. Keep your wake time the same, regardless of what you're doing. Try to dim your lights after 8 p.m. In anticipation. So red shift your lights after 8 p.m. Tonight, you guys are making me stay up because I got my lights on, and these lights are all blue shifted so that I look better. But yeah, dim your lights down. Try to have less screen exposure after 8 p.m. And that's assuming that you're going to bed at, say, roughly 10 o'clock. Nothing to drink after 8 p.m. because that's something else that will keep you up, and nothing to eat after 8 p.m. So you have to be, so that's called sleep hygiene. All of these things that you do around your sleep, you want to keep your sleep area pretty cool, cooler than the rest of you, because that's what happens when you go to sleep. Your body temperature drops, and then in the morning when you start to wake up, your body starts to ramp up, your body temperature comes back up. So you actually want it to be a little bit cool. One of the things that I've been playing around with recently is using a little bit of brown noise or random noise. So a lot of times when I go to sleep, I have on my phone an app called Windy, and it can do rain, it can do wind, it can do a bunch of other random noises. And so I put that down at a very low level. So that's playing in the background when I go to sleep. And I also try to do some box breathing. So box breathing, for people who don't know, is where you breathe in for a count of 4, hold for a count of 4, breathe out for a count of 4, and then hold for a count of 4. And then I repeat that cycle, 4 times minimum. That's something that special forces guys do to reduce their level of anxiety and relax. So I've started to implement that when I'm feeling anxious or tense, and I do it before bed. So those are things that I do to deal with that. I didn't do any of that shit during residency. I only learned it afterwards. So if you are a resident now, bro, start doing that now. Get in the habit, right? And for anybody else who's having problems with sleeping or insomnia, get in the habit of doing those things now. Gilbert Galvin, I have a bulging disc. Will it make it worse by running long distances, like 6 or 9 miles? So if you have a bulging disc, that's fine. It doesn't mean that you have a death sentence and you have to stop activity. You just need to be smart about what it is that you're doing. So a bulging disc is better than having a protruding disc or a herniated disc, right? So that means that the contents have not broken out, spilled out, and that they're not pressing on any nerves at the moment. But any of those things could happen if you don't look after it. So things that are important for you is we want to maintain the elasticity of that disc. So we want to make sure that you keep yourself well hydrated, right? You don't want to be dehydrated, because the thing that contributes most to that elasticity is the amount of water content that is in the disc. And so if you are well hydrated, then the disc will be well hydrated, and that will mean it's more flexible. And then you want to try to strengthen all of the structures around. So that means your core, your low back, your quadriceps, hip flexors, and your glutes. So all of those things work together to help stabilize your spine. And stability of the spine comes from static factors, which are the interaction of the vertebrae, articulation of the vertebrae one with the next, and also with the discs. And then, and pardon me, also the ligaments. And then you have dynamic factors, which are the muscles all around. And the static factors and the dynamic factors each, contribute a percentage. Let's just say for argument's sake, it's 50-50. They come together and they give you 100% stability. If you are lacking a little bit over here, in order for you to have full stability of the spine, that means you need a little bit more on this side. So if your static factors are lacking a little bit, i.e. you have some kind of disc abnormality, then your muscles need to be stronger to compensate for that so that you have overall stability of the spine. So I would work on all those stabilizers to make sure that they're in good condition. And then I would just be cautious of, not necessarily avoid, but cautious of the movements that might predispose you to having an issue. So our spines are capable of forward flexion, extension, backwards, lateral bending, and rotation. All of those things occur, and you should be able to do all of those things. But most frequently, disc herniations and protrusions occur posteriorly when you forward flex the spine. I'm not telling you to avoid that, but what I am saying is that you should think about how you engage in the activity and whether you have enough strength in the muscles around that area to allow you to do that in the setting that you are trying to do. So in other words, don't try to deadlift 400 pounds with a curved back if your spinal erectors are weak, because you're just setting yourself up for a potential problem. So with respect to running, sure you can, but you want to make sure that you provide the best scenario for spinal health. So that means to make sure that the muscles on the front, the back, the core, they're all strong. And I wouldn't just be doing running every day. I just think that in and of itself is not a good thing. That sets you up for repetitive stress injury. So I think that people should be cross-training and doing lots of different things. Let me see here. Under my community post. Oh, sorry. I would answer the question under my community post, except that I'm having a hard time managing both. I'm managing this chat and I definitely need to have a moderator moving forward because I need help with this. Let me see here. Kendrick Lama. Let me just quickly see if I can find it here. Under my community post, Kendrick Lama. Kendrick. Oh, because of chronic back pain. Oh yes, actually. So we were talking, my wife and I were looking at this. We talked about this before. So Kendrick says, because of chronic back pain, I got prescribed Dilaudid for about 3 years already. I'm not abusing it or anything like that. I'm only 26. I wonder if I will ever have a relatively pain-free life again one day, but I just don't know. So here's the deal. At 3 years of Dilaudid, you have a dependency. That's not to say that you are addicted. It's just to say that your body has become accustomed to having that. And so what you perceive as a normal level is like what is required for you to have a normal level of pain or a minimal level of pain is going to be significantly less than the average person because you have so much of this Dilaudid on board. And number one, you have a physical dependency at this point, which you can't just stop cold turkey. You need to actually have a pain specialist help you to get off of that. It also just means that your pain receptors have been sensitized to the point where were you to stop it right now, then the levels of pain that you would experience for a given stimulus. So say you had a small stimulus, which might not cause normal person pain, is going to cause you a significant level of pain. So those are things to keep in mind. For anybody who has back pain, whether there's somebody who is arthritic or not, whether it doesn't really matter what the back pain is caused by. For all these people, studies show that people who work on movements of their spine, both like all the movements that I talked about, and they work on strengthening of the core, the low back, the muscles of the front and the back of the thighs and the glutes. Those people, regardless of what they have, will do better than when you compare them against people who don't train and do any of those exercises, then they're going to do better. So number one, the first thing I'd say is that you need to get with somebody who can work to develop a program for you to train your low back. And listen to what I'm saying here, Kendrick, because this is a little bit of tough love here. I understand that you have had long-term low back pain, and I understand it hurts. There will be no way for you to get better to a point where it doesn't hurt without going through some fire. None, right? So you, from the outset, have to say, if I want to get to that point where there is less pain or no pain, I need to actually experience some of the pain to go through, like, to get better. Because I can tell you now, if you start doing all these things that I'm advocating in terms of exercise, your back is going to be sore. It's going to be sore because of the amount of opiates that you're taking and the duration of time over which you have become dependent on them. So, but hear me out again. Studies show that you, when compared to somebody who is the same as you but doesn't do the exercise, if you do the exercises, your outcomes and your experience will be better. Your pain level will be less than the person who doesn't. So the worst thing you can do is continue to take the opiates and do nothing. But if you want to get off the opiates, you want to get to a point where you're normal, then you really need to start training with somebody who can start to at very low levels, incorporate movements and start to strengthen those areas that I talked about. And then over time, you will progress those exercises in terms of difficulty and intensity as the muscles become stronger. As the muscles become stronger, your spine will become more stable. As your spine becomes more stable, you're less likely to have pain. As you are less likely to have pain, then with the help of the pain specialist, you can wean yourself off of the opiates. And eventually, if everything works according to plan, you can discontinue the opiates entirely and continue on with a maintenance exercise program for your core, low back, and thighs. That's what you can do. So and I certainly am feeling for you, man, because you are only 26 years old, and that is shit situation that you are in. I wish you the best of luck, and that's the approach that I would use. But I am telling you, it's going to be a hard road, and you should prepare yourself for that mentally first before you try to do that, because otherwise you're just going to rebound and you're going to continue to take the opiates, and you may even need higher levels. So you need to be mentally prepared for that before you start to do that. But that's the approach that I would use if I were talking to my own patient. And again, I can't give you specific medical advice because I have not examined you, right? But that's the approach that I would promote, and that's the approach that I would use. Mr. Gonzalez Huey. Hi, doctor. Any advice for a 54-year-old diabetic man looking to lift weights to gain muscle to help with blood sugar levels? Oh, listen, Gonzalez Huey, man. You first things first. You just need to start becoming active. I do think everybody should lift weights all the time. We should all be lifting weights, and we should all be doing resistance training. But the first thing you need to do is just start to be active on a regular basis. And so you can start resistance training, but if you've not done that before, then you're just going to make yourself sore, and then you're going to want to stop. So the first thing is to start doing exercise find something that you like, something that you can do on a daily basis every day, and then start to do that. And just get in the habit of being active on a regular basis. And start out small with something that's attainable, 10 minutes, 15 minutes, whatever. And then once you get in the habit of doing that, then you can start to incorporate some resistance training. And to be honest, I think we all should be doing resistance training. And I lift weights, I lift kettlebells, and I'm a big advocate of lifting heavy shit. But I'm not always doing that. A lot of what I do is body weight. You don't necessarily need to be bench pressing, a ton of weight or squatting a ton of weight. There are lots of ways to build muscle. Like you just look at a lot of guys who are in jail or in prison, man. And a lot of those guys get super jacked just by doing calisthenics and body weight training. So you can do that. But that's how I would start. Start out simple, find something that you like, get in the habit of doing stuff every day, and then slowly start incorporating more and more activities. Start out with some simple body weight training. And if there is a book, there's book 1 and book 2. If you're looking for body weight ideas, which don't require any equipment, Convict Conditioning 1 and Convict Conditioning 2 are a great place to start. Okay. Thank you very much, Blaze. I hope you had a good Christmas too. Would you be willing to do an episode if it's too hot? The AMA involves a slashing wound. I don't know, Legacy. Oh, wait. Oh, I witnessed a physical trauma a customer of mine suffered from someone who tried to attack him. I'm not sure describing is safe for YouTube. I don't know, Legacy. I'll check it out on my email, and then I will, if I think it's, kosher, or think we can do something about that, I'll post about that in the community page. So Davy Jones, how does it work with vets and docs? Like, is there a point where the docs help out vets, or any interesting facts you could share? Usually there's not that much crossover, to be honest, Davy. We do a lot of similar procedures, yes, but we don't generally help each other. But having said that, I have 2 patients on my active list at the moment that are both vets. Actually, they happen to work together. And I've replaced both hips on one, and then I'm going to replace a hip on the other guy. But yeah, generally there's not a lot of crossover, other than that some of the procedures that we do are similar, but we don't generally have an opportunity to help each other. MJO says, I have a disc arthroplasty at C5 and 6 and a moderate herniation at C67. I have a spinal fusion from T2 to L5. Whoa, from scoliosis 10 years ago. In my shoes, would you get another disc arthroplasty at, I'm assuming, so it says L6, L7, but I'm assuming you're talking about, since there is no L6 and L7, I think you're referring to the C6, C7. So here is the thing about spinal surgery, man. The spine is designed for movement. And it's a very well-known fact that once you fuse a segment of the spine, you're going to set up the spine at some point in the future for degeneration of the segments adjacent to that fusion, either above or below. And as I said, the spine is set up for movement. And so if you fuse a segment, the movement just gets intensified around it. So the spinal segments above and below see more force, and eventually you're going to have to do other procedures at those levels. So I can't tell you whether you should or you shouldn't. What I can say is this: what you should do, I wouldn't necessarily do something because you have a herniation, right? Herniation is an imaging finding. And if I pick 100 people at random off the street and I image them with MRIs, as I said to you before, especially a 3 Tesla magnet, is very, very high resolution. It's a very powerful imaging device. And even though not all of those 100 people that I picked at random are going to have pain or some issue, the MRI is going to find something on everybody because it sees everything. So having said that, because you have a herniation, it doesn't really matter unless you have symptoms that are caused by that or that are associated with that. So if you have loss of motor function in a nerve distribution that is associated with that area of herniation, or if you have lack of sensation in an area that is innervated by that area, or if you have some other loss of function that's associated with that, those are indications for a surgery. Just the herniation in and of itself is not, right? It only is if it becomes symptomatic. And so at the C6, C7 level, if you start to have numbness or loss of function that's going down into your hands and has altered the function there, then that is a point in time at which you can consider a procedure. Another procedure is likely going to be in your future, but it's more a question of when. And just the fact that you have a herniation alone is not an indication. It has to be associated with some other loss of function, whether that's sensation, motor function, or some other special function. So that's what I would say, and only you can decide that. I often tell people that they need to have issues more times of the day than not, and more days of the week than not, and those are the considerations. Those are the times when they should consider having a procedure done. If it's less than that, then you can potentially manage it with other stuff, including activity modification. For the emperor, yes. Okay, let me see. Since Liz Allen says, since kyphoscoliotic Ehlers-Danlos is a thing and not just hypermobile, why isn't the blood test given for it when scoliosis is found? I think that's because scoliosis as a condition is way more prevalent than is Ehlers-Danlos, and so not every person who has scoliosis is going to have Ehlers-Danlos. And there's a cost that's associated with that. So it has to do more with management of healthcare resources, right? So doctors go, well, what's the likelihood that this scoliosis is going to be associated with Ehlers-Danlos? Probably pretty low. So unless there are some other indications, we're not going to do the testing. And there are other things that you can do, other tests that you can do. So you can calculate what's called a Benton score, which looks at other things that you can do. How much does your wrist hyperextend? Are you able to touch your thumb to your forearm? How far back can you hold your index finger? A bunch of things like that that will give you an idea that someone might have Ehlers-Danlos. And so if you have a high Benton score, and offhand, I can't remember what the actual cutoff number is. I want to say 9, but I'm not sure. I'd have to look it up. And so probably what would happen is that if you had scoliosis and then you had a high Benton score, then they're going to do the blood test. But if you just have scoliosis, that's common, right? Idiopathic scoliosis for which we don't know why it occurs, that's relatively common. And there's no reason for us to assume that you have Ehlers-Danlos just because you have scoliosis, because you could have scoliosis for a lot of different other reasons. Hey, Doc, anything to keep in mind after tweaking neck on barbell shrugs? Trap seized up for days. Cheers, Merry Christmas. No, I think that's something that, so obviously, either the weight that you were lifting was too much at that time, or your muscles were too fatigued for the number of repetitions or for the duration of the workout that you were doing at that time. And so depending on what other exercises you may have done, you may have pre-fatigued yourself, even if it was weight that you had done previously, no issues. So initially, you just need to kind of lay off that thing that you were doing. I would continue to work on movements to make sure that everything doesn't stay seized. And I would start doing those movements right from day one and start out with gentle movements. And then as you start to become more comfortable, then you can increase the length, the range of movement, both up and down. But I also would work on some retraction and protraction of the scapula and the shoulder blades as well. And then slowly, with a very light weight, i.e. just the bar, start going back to shrugs and making sure that you don't have any of that electric shock type of stuff. And basically, what's happening is when you ask for the muscle to do something which it's not able to do, you send a lot of signals to that muscle, and it really contracts very, very hard, and you get a lot of spasm in that muscle. And you have to remember that the nerves that innervate each muscle, some of them lay on top of the muscle, some are underneath, and some go through the muscle. And these nerves can be like a millimeter in diameter, and they are very soft if you ever see them. And so you can be doing shrugs and whatever, and you have a muscle spasm, which clenches the muscle very, very tight. And then any nerve that is trapped in that muscle will be likewise crimped. And as soon as you squish a nerve, if you've ever banged your elbow and you get that funny bone feeling, you get a zing down your arm, that's because you have compressed the nerve, and nerves don't like to be touched. So when you have spasm in a muscle and there's a nerve going through it and you squeeze the shit out of that, then you get, likewise, you get that zing, which goes down, which is just abnormal sensation, abnormal signals that are your body is receiving from that nerve because you've crimped it. So it doesn't mean you've damaged it permanently. It just means that you kind of squished it. It's not really happy, but you need to kind of get rid of the spasm. You need to get that muscle moving again. You want to get the muscle to be nice, soft, and compliant, right? Nice and soft, because that is when there's going to be the least amount of pressure on that nerve, and you're going to have the least amount of symptoms. Let me see. Might be a touchy one. Oh my goodness, Miss Trissa, what does that mean? Thoughts on trans athletes competing in their desired gender, specifically male to female persons who have undergone male puberty, irreversible bone structure changes, etc., etc. Sure, this is going to be sure. Someone set me up to be canceled. So listen, this is what I think. I don't want to offend anybody who is a trans athlete, male to female or female to male. You know, however you feel is your business, right? But this is what I would say. We have to recognize that how somebody feels on the inside is different than what the actual physical capacity of the body that they have on the outside. And so if you have a male to female transitioning athlete that has already gone through puberty, the odds are that they are larger, they have more, a larger lean muscle mass, they have a larger skeleton with longer levers, longer bones, longer levers than other athletes in the sex that they have transitioned to. So if you were male to female, you were male and became a female, and you're competing against other males, even if you after puberty, even if you've had hormones to feminize yourself, your skeleton, your muscle mass are likely to be different. And once you go on female hormones, you are going to lose some of that muscle mass, but you're really not going to change your skeleton to any significant degree. And so I think that we have to recognize, and I'm not saying that these people don't feel like they're female. They might feel that they're female, but from a physical perspective, their body is different. And so I'm not sure what the solution is, and whether we need to have these athletes participate in a separate class, or if they don't participate in a separate class, they need to there needs to be some kind of adjuster that is used to it's very difficult because if you're in an individual sport, like say you were in swimming, then I would potentially I would not necessarily be against there being some kind of modifier that happens to their time or whatever, or like say it was like some kind of running event, potentially some kind of modifier to their time, so that you can take that difference into account. Now, having said that, I'm not a long distance runner, but I could see that there are lots of females. Like I'm 6'2", I'm 205, 210. And I could see that if I say it's a long distance running event, there are lots of females that are half my size that would run absolute like laps around me. And so it may not make any difference. It might make a difference, say, if I was if I was sprinting and then I competed against other, as a male to female, I became a sprinter. And then I competed against women who were half my size. And that might make a difference, but maybe it wouldn't. I don't know, because there's lots of guys that I competed against in track that were substantially shorter than me, and they were way faster. So but I do think we do have to recognize that there is a difference between the way someone feels and what their physical capacity is. And so that is not something that we should just ignore. We need to figure that out. And I think that there is probably a way that we can do that, which is still sympathetic, or at least it takes into account the way a person feels, right? Because I can't tell how someone feels on the inside, so I can't. It's not my place to say, oh, well, you used to be a male, you can't compete now that you've transitioned to a female. I don't think it's my place to say that. But what I can say is that well, your skeleton is like way bigger and your muscles are way bigger than these people. And that's not like, that's just something that inadvertently happened, or that's something that just happened as you were developing as a male. And which is almost kind of like, well, saying to the females, the people who were born female and competed as female and are female now, it's almost like them being on steroids for all of their developmental period, and then coming off steroids after they've grown into a giant. So yeah, there is that we need to consider. Anyway, I'm gonna let that one go. Oh my goodness, who is that? Somebody gave me, Evil to Hope. I believe that when the pharmaceutical industry was allowed to start advertising in 1855, it has the direct effect of over-medicating the populace. Yeah, that's possible. That is quite possible. So, we do have to recognize that, again, there are lots of diseases and lots of conditions that we have treated as a result of modern medicine. And anytime you have business involved, then there is the potential for there to be some kind of harm that's associated with that business, because ultimately the business is in it for making money. But I will say that when you consider that, one of the things to keep in mind is that businesses are at the behest of their shareholders. And so people want their money to make money, and they don't like when a business is not making money. And so we are in this cycle now where businesses do shady things because they want to make more money, because the shareholders will kick out the board of directors or the people in charge if they're not making money. And so if people really are concerned about that, then people need to be more supportive
of companies that put the patient first and don't put the almighty dollar first, right? So we as a population, when we invest in companies, we need to put our money into companies that behave ethically the way that we want instead of the other. Because if you have in your investment portfolio any of these funds from any of these companies, then you are complicit in that behavior, right? And I know that there are shady things that happen, but I also know that there are a lot of medications that we have now that are very effective for a lot of diseases that we would not have otherwise had if there was not these pharmaceutical companies. So, oh my goodness, Joseph Coletti, you are a boss, man. Thank you very much. Greatly appreciated. Just because I appreciate that. Dennis Bolanos, thank you very much. What is my opinion of orthopedic chiropractors? Well, like I said before, I don't hate all chiropractors. Orthopedic chiropractors, like I'm not familiar with that specifically, but as I said, chiropractors I think have a specific role in MSK spectrum, and their role is in the treatment of acute back pain. I think that they can do that. I don't think that manipulation is required for them to do that, but I think that's where their sort of bread and butter is at. And if you look on my Instagram, for anybody who's on Instagram, you can check out, I have a number of interviews there with chiropractors. Aaron Kubal, who's big over here, big on YouTube and big on Instagram and TikTok. Raymond St. Augustin, Bobby Maybe, and Matt Colby, 4 chiropractors, with whom we discuss the place of chiropractors in the treatment of MSK issues. So I think that they have a role, and I don't hate them all. I just hate bullshit. And people who talk, if I hear a chiropractor start talking about subluxation, man, that's a problem. That's like a red flag for me. So yeah, do I hate them? Nope. Do I think they have a place? Yep. They just need to know what it is. Okay, so Australian said, hello, I had an emergency laparotomy 6 months ago. The left side is about 1 centimeter higher than the right side when they stitched me up. Is that normal? 2 lumps where that started, which they say is herniated fat. It's possible. It depends on how much subcutaneous fat there is. So how much fat below the level of the skin above the peritoneum. And I often will, or not often, but sometimes when I do hip surgery and I sew the hip up, sometimes there will be a little bit of fat necrosis underneath the skin. So if you have a significant layer of fat, and as we cut through it, fat is relatively vascular tissue. And sometimes some of that fat, after you sew up the wound, will die. And so the patient will have a little divot there. So it's more of a cosmetic thing. It's not a big problem, but it can happen. And it just means that you probably had a little bit of fat necrosis underneath the level of the skin. So nothing to really be concerned about. Oh my goodness. So that's, yeah. So that was awesome that Joseph Coletti just donated just because, which is very, very generous of him. I appreciate that. So thank you very much. Let's go on. So CBSS, man, welcome to the live stream. So how do you know if a supplement brand actually has the supplement in the pill, especially in America? Freaking good question, man. So listen, so here's one of the things that in America and Canada, because supplements do not fall under the Food and Drug Act in the United States, or Health Canada or Drug Canada, whatever it's whatever is the associated affiliate in Canada, supplements don't necessarily need to put all their freaking ingredients in it, man. So there is no requirement for them to say exactly how much of a particular thing. And you really need to be careful when you are purchasing supplement to know. So one of the ways that you can kind of assess ingredients are ingredients are listed in their in the order of their volume within that thing. So you kind of have to look at how much volume or what is the weight of a particular capsule, and then you kind of have to do a little bit of research and look to see how much what is listed in what orders. And then if they give you an amount for any, thing that's in there, medicinal or non-medicinal, then you kind of have to do some detective work to figure out from that what is the quantity of the active ingredient. But it's a little bit tricky, and sometimes you have to do a lot of detective work. Vancouver Open BSD. Could you do a video on judicial hanging? Apparently it kills mainly by trauma to soft tissues and vasculature, not by spinal cord transection. So there is a video that I've done on some of the tortures in history. I can't remember if we did hanging. I know we did the guillotine. I have to check back because I've done like 3 installments, and I think that might be one of them. But if not, I'll have to check this afterwards. But if not, we're going to be doing more in that series of weird, gruesome tortures, and I can put hanging in there. So there is, there's a number of things that are involved with that. So I'd be happy to talk about on that and certainly do a video on that topic. TS Long says, I was wondering about isometrics, bands, straps for resistance training for us older folks who have already had heart attack to maintain and grow muscle mass and strength. So listen, TS, I'm a big fan of isometrics. We use bands in our gym. And if you follow the stuff that we do online, Human 2.0 Fitness, a lot of those, not all, a lot of the stuff that we do is body weight, and we use a lot of kettlebells. But as we are training for that video series, a lot of the stuff that we do is at home. We are using bands, and there's nothing wrong with resistance bands. And as I said earlier, you can do resistance training just with your body weight. But don't think because you've had a heart attack that you can't do resistance training with weights. Of course you can. You should speak to your cardiologist or your cardiac surgeon first to know what is, what you are allowed to do based on the medications and, based on what your current cardiac function is. But you can certainly do resistance training and certainly use weights. That's not a problem. It's just about what is your level of exertion that you are allowed to do. So that's what I would say. But if you're looking for ideas about things to do, certainly you can follow us on Human 2.0 Fitness. That's our gym channel, and there are stuff that you can do there that you can modify. Right? It's all body weight. It's all mostly body weight. Some bands, some resistance. Cereal Spoon says, "How has racing impacted my journey?" Well, here I am. I live in Canada. I'm an orthopedic surgeon. I'm a Black man, and I'm a fully trained orthopedic surgeon. So I was able to make it. Both of my parents were factory workers, and I was able to come from that to get to this point. That being said, it was not necessarily an easy journey for a number of reasons, one of which was my race. And there have been things along the way where things that happened that were largely a function of my race. Not that I couldn't overcome them, because clearly here I am. But they happened to me when they would not have happened to people otherwise. And some of these things are relatively minor. Some of them are much more of an issue. But I'm part of a mixed marriage. My wife is white, and my wife has been with me now for we've been together for 36 years. And there are quite a few things that she has experienced where she has said, "Oh, geez, man, like I had no appreciation of this, of what was happening beforehand because I was the first Black person that she was involved with, and that now she's like, oh, okay, well, yeah, people sometimes do act differently for no other reason than the color of my skin. So all of that is to say, there were some challenges, but it was not anything that was insurmountable. Were there things that I wish were otherwise? That's a tough question. Probably yes, but also those experiences allowed me to be what I am today and to think the way that I do. And part of that is what has prompted me to look to be able to expand my reach by using social media and using this platform. So if someone said to me, well, you could wipe all of those issues from your past, all of those things that you had to struggle through, but it meant that you had to stop speaking to people on social media and stop educating people in this manner, would you do it? And I'd have to say, no, I wouldn't. I wouldn't do it because I love interacting with you guys. I love creating content for you guys. And so did some of those things suck? Yes. But here I am chatting with you guys, and that's cool. And so was the price worth it? Yes, I think so. Boom. So, sorry, you've done martial arts as well. Thank you for answering my questions. No problem. Can't kick no more rugby after that. That fat bone in my knee, cracked metal, in there now. Can walk, run, but can't kick, and no more rugby after that. Oh, so I assume you're talking about the end of the femur. And so you had fixation. Well, depending on what level you had it fixed at, if you had a plate, then it may be that it's difficult to run because of that. But if you had a rod in there, then you should be able to run. Like ultimately, I would, if you were my patient, I'd want you to be able to go back to doing whatever you were doing prior to. Channel Zero, thank you for all the great information. No problem, Channel Zero. Love to do it, man. I love teaching. And Winnie the Pooh, thanks for everything again. No problem. Mr. Red, what up, bruh? Wee Liang Loon. Why did Wolfie stop making videos? So that's good. That's a good question. So he kind of stopped for a number of reasons. One of which he came home. So he was, as you know, he was living in Los Angeles at the start of COVID. When we didn't know what COVID was, and when COVID first started, I made him come home because I wanted him to be in Canada. I have no access to the medical system in the United States, and I didn't know what was going to happen, so I wanted him to be home. So he came home, and that took him out of his environment where he was working with lots of other content creators in Los Angeles, filming content all the time. So he was a little bit depressed about that. And then, he just kind of got in the habit of not doing stuff. And he was trying to transition out of what he was doing at that time because that content was much more targeted towards younger people. And as he gets older, his interests change. So he wanted to transition to other things. And so he's kind of been doing that. The other thing that he really wanted to work on, so all the OGs know that when Charlie started, his thing was music. That's what he started initially. And then he was kind of doing a little bit of comedy, but mostly music. And people really jived with comedy. They weren't jiving with the music so much. So he went full steam ahead with the comedy. But being off for COVID, he really had time to work on the music. And he has so much music content that he has created over the last couple of years that he wants to put out. And he's just not really done it yet. There's so much good quality stuff that he has because my wife and I are listening to this all the time. And when he's doing this stuff, he has us listen to it. And that has been his focus. And I think that's what he wants to really do now, is to do music And then also, if you guys are following him on IG, TikTok, and on Snapchat, he's really focusing or transitioning to doing content there, where he doesn't need to spend as much time editing. He can just do humorous stuff, quick takes, and also lifestyle stuff. Because as he gets older, as him and Sylvia start to transition from a dating couple into potentially a married couple and have kids, that's what they want to do, stuff that reflects what they're into now. So they want to do that kind of content. So he's not really going to be doing long form content, I don't think. Maybe, we'll see. But mostly he's going to be wanting to do some music stuff, some lifestyle content, which is of shorter duration on those other platforms. So you guys can check him out there. What else? I'm going to take a few more, and then I am going to call it an evening. So let's see. Any more 4K themed vids from Brass Mustache? Yes, most definitely. What do I think about Benadryl to help you fall asleep? Hey, Autumn Spielberg. So I talked about stuff to do for falling asleep before. Benadryl, no bueno, man. Not because it's not good. It's just that it's a medication that if you are using it and then you get used to using it, then you're not going to be able to fall asleep otherwise. So, and not to mention, you're taking this thing for no reason. So that's something that I'm not a big fan of using it. Let me see, 3 more. So Dr. Chris, Smart Physical Fitness, Dr. Chris, I made a wellness playlist on my YouTube channel. If you have time, criticism from you would be great. I linked a few of your vids in it. More soon when I have time to watch more. Okay, I'll have to remember to check that out. Yes, I'll have to check that out. Smart Physical Fitness. And you can always send me a comment at any time, and I'll try to remember to check your stuff out if you'd like from that. Nicholas Quintana, question: when you were in medical school, what was something you learned that blew your mind? Listen, man, Nicholas, when I was in medical school, there were so many things that blew my mind. Everything, because I didn't. I had a biology background, but I didn't really have a medical background or a kinesiology background. So there were so many different things that I learned, and I found it so fascinating. The biggest things that interested me, that I found fascinating, were just the anatomy of the human body and how that worked together. And that's one of the reasons why I went into surgery, because I love human anatomy. And I love how the muscles, nerves, bones, ligaments, all those things work together. And so that is what I found the most interesting. And that's why I kind of became an orthopedic surgeon. Okay, 2 more. Have you personally had to have orthopedic surgery? Oh, Michael Hernandez, great question. Oh yeah, man. I've had 5 surgeries. I've had 3 on one knee and 2 on the other knee. So for those of you who don't know about my past, so when I was in university, I played football for University of Western Ontario. So at that time, Western was kind of like Canadian equivalent to an Ivy League. People have argued that it's not that anymore, and maybe I haven't been there for a long period of time, but at that time, it was one of the best football countries in Canada, or football programs in Canada. So I played there, and then I was drafted in the CFL draft. So our what people would say Farm League, Farm League NFL. So our equivalent to the Canadian Football League. So I was drafted there. During my career in football, I had a couple of knee injuries. So I had to have surgery. And then my knee was not the greatest afterwards, that one knee. So when I was retired from football, doing other things, I injured that knee. I injured that knee doing Taekwondo. I injured that knee personal training and teaching fitness. And then on the other side, I injured my knee playing basketball. And then I injured my knee during military training. That second knee I injured during military training. So in total, I've had like 5 knee surgeries. The last surgery I had was probably about
8 or 9 years ago. That was the one that I injured during military training. But since then, my knees have been fine. They're getting older for sure, and they don't feel like they're 18 years of age anymore. But my knees are doing fine. Let me see. And last one for today. And by the way, thank you very much for hanging out with me, you guys. You guys are freaking amazing. This has been more fun than I anticipated. It's the first time I've done it. And I think for sure I'm going to do this again because I love answering these questions. And, I love hanging out with you guys. Yeah, it's just, this was a good experience. So let me see. It's the last one. Okay, so Christopher Bilko. So I talked about this a little bit before. So have you seen people abuse melatonin, sleep aid, and several doctors are now going away from prescribing it? So yes, I've seen that. And let me reiterate what I said before. So melatonin, your body makes melatonin. It's the thing that makes you want to sleep at night. It's what tells you that it's sleepy time and it's time for you to go to bed. So your body makes some. So as soon as you take some externally, the amount that your body makes is very small, and you respond to very small amounts. The amounts that you can get at the store, 3 milligrams, 5 milligrams, 10 milligrams, are like a freaking sledgehammer to your brain. And they overpower by orders of magnitude the amount of melatonin that your body produces. So when you start taking this external melatonin, it's way more than what your body produces, and it makes it so that you are not going to be responsive to the small amount that your brain produces anymore if you start using it habitually. So when I was having issues with sleep, my sleep doctor told me that I should use it no more than 2 days in a row, and I should use it no more than one application or one set of applications, so 2 days per week. And that was it, because then you need the other 5 days after you've hit your brain with a sledgehammer 2 days in a row. You need the other 5 days for your brain to come back to normal and for it to be responsive to the amount that you are getting endogenously. So I didn't use melatonin as an aid for falling asleep. What I used melatonin for was a way to reset my sleep cycle. So if I was during residency, we did shift work, and sometimes we were up at night and whatnot. So anytime that I had done that kind of stuff and my sleep schedule was off, I would use melatonin at the beginning of the week to reset my internal clock. So whenever you want your bedtime to be, take melatonin once or twice, once or 1 or 2 days at that set time, so that you would be, so that your brain would get back in its normal circadian rhythm, and then don't take it after that. And you should take the smallest dose that is that works. So you should start out with 3 milligrams, and if 3 milligrams doesn't work, then you can try 5. Now they're doing 10 milligrams, and again, that's just like absurd, man. You don't need that much, but you need that much if you're using it like habitually. So you should only be using it maximum 2 days in a row. I don't often tell patients to take it, but if they're having trouble, then I will suggest that. But there are other things that you can do to, make sure your sleep schedule is normal. And so, like I said, dim your lights after 8 p.m., red shift the lights, nothing to eat or drink after 8 p.m., start to turn your thermostat down at night, keep your bedroom a little bit cool, keep the screens out of your bedroom. All of these things, which are easy sleep hygiene things to do, that will help you with insomnia. So if people are using melatonin, many people use it regularly, habitually, and they don't use it properly. And so it has no effect. So then they need to keep using more and using higher doses. So they shouldn't be doing that. Anyway, that being said, I'm going to wrap it up.
I gotta get to bed here. I haven't eaten. I'm breaking my rule because I was chatting with you guys. I haven't eaten supper yet, so it's like almost 9 p.m. here. I gotta go eat something, and I gotta start to wind down so that I can get to sleep at an appropriate time. But thank you very much. You guys are freaking amazing. The intern army is awesome. And I look forward to doing this again. So if you enjoyed this, be sure to let me know in the comments section or on my community page on the post. And I will try to do this more often. Who knows? Maybe I'll do this like once a month or something like that. But yeah, thank you very much, guys. Have a good night or a good morning wherever you are, because we got people from all around the world. And I look forward to doing this again with you in the future. All right. Peace out. I'll see you guys. Oh, wait, no, I suppose I should do the outro. As always, that's been a word from Dr. Chris, not your everyday ortho, where we see one, do one, teach one. Good night.